So how we might improve hypertension. Good news is very responsive to an exercise intervention. Hypertension is readily improved. Just physical activity brings about consistent but small improvements in mean blood pressure. And so 4 to 9 millimeters of mercury of change just by increasing daily physical activity engagement. Walking, taking the stairs, doing more active chores like laundry, etc. But a small contribution to our daily activity can bring about a small improvement in hypertension. And then we get added benefits from improved fitness, namely a decrease in the resting tension in the arteries, which we talked about last class. It's a small, hard to quantify amount that differs by the individual and the level of fitness improvement. We get contributions from weight loss, so less compression on the arteries, relatively large improvement overall. And then also sodium reduction has been shown to improve hypertension as well, being that sodium is the main cation in the extracellular space in the blood. And sodium pulls fluid by osmosis. So if we try to get rid of sodium, there's less pull, less fluid in the vasculature, and less tension, less pressure. Now these are fairly large ranges, and there's no indication of time. Of course, it varies for everyone, and it's not to say that if you start exercise, this will happen tomorrow. But I'm going to show you some research that's pretty convincing, where one acute bout of exercise can bring about noticeable improvements in hypertension, called post-exercise hypotension. The phenomenon that we're describing. And then stringing those individual bouts together is what brings about that chronic improvement, post-exercise hypotension. These are independent and they're additive, so we can add the 4 to 9 with an improvement from weight loss and sodium reduction if we decide to engage in all 3 or 4 of those factors. So you can imagine we can bring about fairly large improvements and robust improvements in hypertension with fairly radical lifestyle adaptations. If you've gotten into a situation like this and these values are skewed, weight is skewed, your level of physical activity and sodium intake are skewed, it would be difficult to get them to quote unquote normal. But with change, we can bring about some improvements in hypertension. And so I'll show you a few studies that get at the scope and the effectiveness of physical activity. And one place I like to start when looking at these kinds of shifts is with large-scale population-based epidemiological type studies. So this is a fairly large study, 16,000 participants. So pretty good statistical power. A lot of it is self-report via mail. At the time this was started, it was in the 70s. This was Ken Cooper. We talked about this like in the first section, one of the turning points of clinical exercise physiology. Ken Cooper in the Aerobics Center longitudinal study. Started back in the 70s, and this has been a follow-up here at least over 18 years, and I believe it's ongoing. Looking at self-report activity and various indicators of fitness, and I won't go into a lot of detail about how each were determined, but their overall conclusions, you can see here, there are pretty consistent improvements in the incidence rate of hypertension with fitness and physical activity, or the level of exercise engaged in regularly. And more often than not, these two overlap, are parallel. The more physical activity you participate in, the higher your fitness, usually. But there are some cases where you can be physically active in a way that doesn't stress the body to bring about changes in fitness. So these elements are separated to get at their independent contributions as far as hypertension goes. And we can see the numbers on each of these bars is the total number of cases in brackets versus the adjusted number of cases per 10,000 man years or person years. So following 16,000 people over 18 years, you get an area under the curve, so to speak, person times years. These are the number of incidents, and then these are corrected for other extraneous factors such as dietary habits, smoking, other cardiovascular risk factors. And interpretation of the numbers isn't necessarily what is important on this slide, simply that we see progressive improvements as you move from low to high cardiorespiratory fitness, lower incidence rates, and progressive improvements as you move from sedentary to gradually more active. And WJR, if you haven't noticed, is walker, jogger, runner, so not structured, organized exercise like you might find in sport. And, unsurprisingly, or not surprisingly, if you combine these two, you have the lowest incidence rate in those individuals that are of a high fitness, regularly active in organized sport. The highest incidence rates in the lowest fitness and most sedentary. Which is technically not true because we have this inconvenient bar here where the walker, jogger, runners have a higher incidence, but the trend is intact. And we'll leave it at that. There's a small enough difference that we'll ignore it for now. Gradual improvement with fitness, gradual improvement with daily PA, which is not really surprising. Now, what this doesn't get at is how quickly these changes occur. Do you have to wait 18 years? This isn't even a time course over 18 years, but these people are contained within these bins. How long did it take them to move from one bin to another? Exercise can do that fairly quickly, and I'm going to tell you the magic recipe first before we look at some of the time course changes. And the magic recipe probably follows suit with any of the physical activity guidelines that you've heard of or read in recent years. Frequency, every day. Endurance exercise, every day. And we're beginning to understand that resistance exercise can also improve hypertension, which is counterintuitive if you think about it, because the straining of muscular exercise, the compression of the arteries, it acutely impacts blood pressure. So during a lift, blood pressure goes up. But then after the exercise, you get that post-exercise hypotension and a loosening or a lower resting pressure in the arteries. So resistance exercise does confer some benefits, and that's only been explored recently because of the expected conflicts by spiking blood pressure during the lift. It wasn't considered safe at first. If you are engaging in exercise, moderate is the way to go, especially if there are comorbidities or the risk of atherosclerosis and rupturing plaques damaging the arteries. You increase blood pressure during resistance exercise and acutely during endurance exercise. The higher the intensity, the more the increase in blood pressure, so moderate seems to be the sweet spot, where you get the benefits of exercise without any potential downside of increasing the intensity too much. And I'll show you some research coming up. There seems to be a dose response. Low, moderate, high intensity activity seems to bring about less, slightly more, and the most improvement in hypertension. So even though we say moderate, there is some rationale for a more vigorous type of exercise if it's deemed that it's safe for the individual. How much? Well, if you're exercising every day and we target 150 minutes per week, roughly 30 minutes per weekday, 30 to 60 if you're trying to progress and improve. And if you are one that gravitates towards resistance exercise, 2 to 3 sets of 10 to 12 repetitions, moderate intensity. The point of this course is not to break down what is moderate and how to do this, but just an example of the kind of commitment that you're looking at. And of course, safe activities. And what we mean by safe are walking, jogging, resistance machines, things where skill is not really a factor and the risk of injury is low. No skill-based activities, things like resistance bands, machines that help to limit the range of motion and position you properly, walking, jogging, things that you do on a regular basis. Maybe cycling if you're good at cycling, not competitive cycling if you're not good with the balance, but safe activities. So let's take a look at some time course, dose response, other particulars related to exercise and its effects on hypertension. First off, dose response. In overweight men with pre-hypertension, so not full-blown hypertension. This is between, well, I suppose these are by the old guidelines. The baseline systolic blood pressure is 128. So it's on the border of being hypertensive, which our new guidelines are 130. We don't have mean blood pressure here, and I don't have a number for baseline diastolic blood pressure. So the message doesn't really change, but I don't have that number to tell you what it changed from. A comparison of low versus moderate versus vigorous exercise, and you can see a brief description of each of those types of exercise over here. 40 minutes at 40 or 60%, and then a graded exercise test or a VO2 max test to physical exhaustion, to voluntary exhaustion or 100% of VO2 max. Notice it was accepted. This exercise was handled fairly well by these individuals. So a comparison of these exercises. And what this shows us is from a baseline, and we'll look at systolic blood pressure first. From a baseline of 128 millimeters of mercury, the control group increased by 10 millimeters of mercury. And the increase is a measure over 9 hours ambulatory blood pressure as they go about their day after the measurement at baseline. So they're wearing a device that measures over 9 hours, and the average change in systolic blood pressure was that it went up by 10 millimeters of mercury. Which makes sense. Any of these baseline measurements are usually done in a nice, quiet, relaxing environment. They bring them into the lab. The pressures of their job are gone for a little while, and so baseline is probably fairly low. It's the best case scenario. And then as they're more active, moving about throughout the day, average systolic blood pressure jumped by 10 millimeters of mercury. If those individuals engaged in low intensity exercise, they only saw an increase of about 8 millimeters of mercury over those 9 hours. If they engaged in moderate intensity exercise, it only went up by 6. And if they engaged in vigorous, over 9 hours there was essentially no change. No increase in systolic pressure over those 9 hours on average. So really nice dose response curve from doing nothing to doing a lot. Progressive decline in systolic pressure in free living individuals over 9 hours. One single bout. That's a pretty potent result, right? One bout of exercise. And the graded exercise test, probably no more than 10, 12 minutes. Similar pattern for diastolic pressure. Diastolic is generally less resistant to change anyways, even with training or with hypertension, but we see a progressive decline the more vigorous the exercise at baseline, the larger the decrease. So overall systemic pressure is reduced. Systolic and diastolic pressure went down on average over those 9 hours. And like I said, I don't have the baseline diastolic pressure to show you what it went down to or where it went down from. But still a nice decrease of about 6 millimeters of mercury in the vigorous condition. So this is our classic endurance type exercise. We've always thought moderate was the way to go, and now we're leaning towards there being an effect with more intense exercise. And this brings up an interesting point too. If you can handle intense aerobic exercise, could you get extra benefit from repeating this? Aerobic interval training, right? We've always avoided it at the risk of damaging the arteries further or hurting the patient. But what if these individuals were to engage in aerobic interval training? And so this is a comparison of, again, one bout of exercise and a follow-up now over 24 hours, not 9 hours. We don't know what happens after 9 hours in the last study. This is a full day, including sleep, after engaging in either aerobic intervals, moderate intensity exercise, or a control. 24-hour ambulatory blood pressure shows a better response, a larger decrease with the aerobic intervals group versus the moderate intensity group, which itself is better than control. Big reductions in both systolic on the left and diastolic on the right over 24 hours with aerobic intervals. Now, I think it's important to mention here, this is matched exercise. They're doing the same amount of stuff. In the last study, you did more work in the moderate group than low. You did more work in the vigorous than moderate group. Maybe. But there wasn't any control for the amount of energy expended. So maybe it's not dose response for intensity, maybe it's just amount of exercise that you do. If you did low intensity longer, there's no way to say that you wouldn't see a greater benefit. Here they're matching the amount of exercise done. So 4-minute intervals at 90% with small breaks in between. You can calculate the amount of energy expended, and that ends up being 47 minutes, very specific, at 60%. These are matched exercise. The only difference here really is the intensity and the pattern of delivery. Much larger decrease with the more intense interval exercise. So this is the kind of work that's shifting our perspective now, changing the paradigm away from just boring moderate intensity exercise. Even though that still works, we get a better improvement, a larger improvement in blood pressure with more intense exercise. Make sense so far? So far, these are all aerobic, and there isn't much information on resistance training, and there really isn't a lot of research out there, or at least when I looked last year or the year before, there wasn't very much that was convincing. That might have changed in the past year, I doubt it. It might have changed, but this is one attempt at separating the effects of aerobic versus resistance training. And the candidate exercise for aerobic here is treadmill. Resistance training was, without getting into the details, a circuit type resistance training. Many exercise stations, high reps, low weight, which in and of itself probably has a cardiovascular component. So it's hard to say resistance exercise does this versus aerobic. So keep that in mind when interpreting this figure. And versus control, this is again one single bout following everyone over a 9-hour work day. So they come in the morning and they go about their jobs, whatever their jobs happen to be, And those individuals that came in and did nothing saw a gradual increase in mean blood pressure over 9 hours. Maybe they're just getting stressed. Maybe it's moving around. Who knows? And all groups, in fact, showed that same increase. Work started with a low blood pressure overall and then gradually increased over time. But the benefit is either exercise group started lower and stayed lower throughout the workday. Any exercise improved blood pressure and maintained that improvement over 9 hours. And I'm saying 9 hours, but I think that's wrong. You're probably looking at the scale. You see 7 hours over here. I think that's probably a typo because I copy-pasted from the 9-hour ambulatory blood pressure. So we're going to say this is 7 hours. The figures don't lie. Still, comparable. We don't know what happens in that 2-hour block that's missing, or for that matter, anything after 7 hours. But both exercise groups saw some improvement. If you were to attempt to rank them, it seems as though treadmill exercise was better at preserving that improvement. It's hard to differentiate between these two, but these closed squares are the treadmill exercise, and there was a gradual persistent increase that was lower in the treadmill group, whereas the resistance circuit group seemed to spike or accelerate near the end of the day. They're both better than control, but if you had to rank the exercise better or worse, it seems like the treadmill exercise, the aerobic exercise, conferred a greater benefit. So, jury's not in on resistance training yet. It's hard to say what resistance exercise might do because this is, again, very aerobic resistance training. Maybe there isn't as much of an improvement if you do higher weight, lower reps, but we don't have that information yet. Yeah, Keegan.
I'm curious, for the last study, the aerobic interval training, were they like, do you know if they were just on a bike or were they doing like a body weight?
Good question.
Because
I'm pretty sure this is a cycle ergometer. Yeah. Most of the studies that pinpoint an exact percentage and do these intervals, it's easier to prescribe on an ergometer. I would have to check to make sure, but that's my first guess.
Okay.
Yeah. Either way, pretty convincing. One single bout of exercise does these improvements. Yeah, Rosanna.
What's the spike at the very beginning? So like
Oh.
right at rest and then just spikes.
Good question. Yeah, I overlooked that. This spike at the beginning is the residual effect of the exercise. So exercise increased mean blood pressure in the treadmill and the circuit training group up to 110 and maybe 104 millimeters of mercury. And then we see this drop 15 minutes later that is maintained through 7 hours. So they arrive to the lab here and take a baseline measure. The groups are separated into either exercise or not. Exercise has these two effects of increasing blood pressure. If you're in control, nothing happens. And then 15 minutes post-exercise, we see the trends follow out as described. Good point. Yeah, I overlooked that. Yeah, Peter?
Is this a measurement of diastolic blood pressure?
Mean blood pressure. So it's a combination of systolic and diastolic.
Okay.
Yeah. How would you calculate mean blood pressure, by the way, just in general? Let's say you're at rest. You're not exercising. You can measure systolic. You can measure diastolic. You use your stethoscope. What would you, or how would you calculate mean pressure, the average pressure in the artery? Remember that equation? Let's think about it this way. Cardiac cycle. Remember the cardiac cycle? How long do you spend in systole? Yeah. And therefore, how long do you spend in diastole? 2/3. So how do you calculate mean blood pressure? Do you want to take a stab at it? You have the fractions.
So you would like make it. I'm trying to say, how do I say this out loud? You would figure out what the average is in diastole and then the average is in systole and combine them but like you would have that be a fraction of like a third.
Yes, you're on the right track. So you would take 1/3 of your systolic measurement, 2/3 of your diastolic measurement, add them together. Yeah. Yeah. The average pressure, because you spend 1/3 of the time in systole, means that it has 1/3 of the influence on mean pressure. Diastole influences it 2/3 of the time, so it's 1/3 systole plus 2/3 diastole. What about an exercise?
It's like half and half.
It's half and half? Are you sure? Yeah, that's exactly right. Yeah, cardiac cycle shortens. What part shortens? Diastole shortens. You can't really change the systolic part of the heart. You can contract more quickly and with greater force and perhaps shorten a little bit. But generally the conduction is fixed. Generally. But yeah, half and half. During exercise, half of your time is spent in systole, half in diastole. So you would calculate mean pressure accordingly if it's exercise. Now those are both approximations. Maybe you spend 2/5 of your time versus 3/5. Doesn't really matter. Those are the equations we use. Would it help to see them? Does that make sense talking about it? Yeah? Let's write them out real quick. So oh, you can't see any of that, can you? All right, just bear with me. And this is probably, maybe that makes sense. Mean blood pressure at rest, 1/3 systole plus 2/3 diastolic pressure. And then autocorrection, the fractions, fantastic. Exercise, mean blood pressure, half and half. All right, we're convinced exercise has potent, acute effects. We don't see the time course for any reversal in these effects here. I suppose at the end of a 7-hour workday, you can argue they're back to where they started. Mean blood pressure has returned to normal, and that's not generally encouraging, but it's also still lower than control. Whether this difference persists outwards, we're not sure, but it makes sense to suggest that if you string together many of these acute bouts, you'll get a persistent lowering of the baseline mean blood pressure and improvement in hypertension. So we're convinced exercise works. Let's take a look now at things that we need to be concerned about when prescribing exercise or testing an individual with hypertension, because it's still a higher risk scenario. Individuals with hypertension are at a higher risk of cardiovascular complications. So if you were ever in a position where you were responsible for somebody that had high blood pressure, you would want to make sure that they weren't likely to injure themselves under your watch, right? And so you might make a measure of blood pressure before exercise or the testing or whatever began. If you observe systolic pressure over 200, diastolic pressure over 110 at rest, they're relative contraindications to exercise, which essentially means you can still proceed with exercise if all other aspects are in line, if they have few cardiovascular risk factors, if their LDL cholesterol is low, HDL is high, fruit and vegetable intake is good, if they're physically active, lifestyle questionnaire stuff would get to the bottom of that. But over 200 and over 110 are absolute contraindications. You would not want someone to exercise in that situation. You'd refer them to a physician and get clearance before engaging in exercise. Let's say that an individual with higher blood pressure, but under these limits, was to engage in exercise. You'd probably want to still monitor. You'd follow the prescription we laid out. Maybe you're doing moderate intensity exercise. Maybe you're going with something more vigorous. But in any case, you're monitoring blood pressure throughout. You're taking breaks to measure manually, or you have an automatic device. And you're measuring heart rate response as well. We wouldn't necessarily expect heart rate to change too much unless they're also taking medication. We'll talk about that in a second. Some beta blockers can have a very specific effect on heart rate, or a specific effect that can be borne out in heart rate response to exercise. Yeah, what is it?
Is it possible to have hypertension induced from exercise?
Absolutely. That's exercise makes blood pressure
Like
go
that,
up.
like
Is that what you mean?
afterwards for like throughout the day, instead of having like a lower blood pressure, if it could raise it.
I don't think it's possible. The post-exercise hypotension is a very consistent response to exercise. I haven't heard of anyone that has experienced high blood pressure after exercise. Yeah. So you're monitoring, and if in that monitoring you observe these acute radical changes in blood pressure, you obviously want to avoid any risk of injury and stop whatever testing or exercise they're involved in. And those limits are systolic over 250, diastolic over 115. Diastolic shouldn't change too much, but of course if it goes up this high, you want to stop. Systolic you might see at 200, 220 normally. 250's getting into that red warning area. Yeah, Sadie.
Just wondering why heart rate wouldn't increase.
Oh, sorry, heart rate does increase.
Okay.
You're looking for abnormal increases in heart rate.
Okay.
Yeah, maybe I said that wrong. Heart rate absolutely would increase during exercise, and more so with more intense exercise. Because we always forget about flexibility testing as normal. Not a large cardiovascular or blood pressure component in flexibility testing, but it is one of the elements that is usually involved in the CSEP guidelines, so we're applying them here as well. Yeah, it's not expected that we see an abnormal heart rate response. And they don't even have criteria for what abnormal would be, but you could probably imagine anything over, what would a nice target threshold for heart rate be? If you saw something over what value, you'd want to stop exercise.
If you're doing like moderate intensity and you get to like 180, 190.
Okay, yeah, if it's moderate and you get to 180, 190, that's certainly cause for concern. If you see, what number would make you just stop whatever you're doing?
Okay.
Over 200, yeah, for sure. Over 200 easily. Not anything new. You've had that hammered home in XPhys, I'm sure. Okay, so exercise testing considerations, just things to watch out for. It feels a little out of place now, but this sort of reprises some of the improvements that we acknowledged at the start. And this is a slide taken out of the old textbook that I've since made a suggested text. I thought it was nice to include here because it shows a few more aspects of fitness or lifestyle change that can improve blood pressure and the relative magnitudes of that increase. We've already, for instance, seen weight reduction. We've already seen a reduction in sodium content and physical activity, alcohol consumption related to high blood pressure as well, and the DASH diet, the dietary approaches to stopping hypertension. Is that what it is? Yep, dietary approaches to stop hypertension. Emphasis on high fiber intake, fruit and veg intake, low sodium intake, low saturated fats. General good diet also has independent effects of 8 to 14 millimeters of mercury as well. What we don't see here, again, is a timeline. We don't know, hey, if I start adopting this DASH eating plan, does this happen tomorrow? Or how long does it take to realize the full benefits? And where do I fall within this range? They acknowledge at the bottom here that dose and time will affect the responses, and it might be largely individual. So keep that in mind if you're ever monitoring someone that has small changes where they're resisting any further change. It might just be an individual response. What I haven't done yet, I've shown you some exercise data. I've stayed away from too much sodium information or dietary information because it's technically in nutrition. We just concern ourselves with exercise and sport, but I do like blending the two a little bit. And especially from a clinical point of view, you don't often only get counseling on physical activity or give counseling on physical activity. You might suggest healthy eating or low sodium approach to hypertension and weight loss. So I wanted to show, this is a follow-up study for individuals that were hypertensive, that were on medication, and transitioning off of medication to a healthy lifestyle. So these are individuals transitioning from hypertensive medication to a healthy lifestyle, and that healthy lifestyle is either weight loss or sodium reduction or both. Plus or minus weight loss and sodium reduction. So there's a control group here versus each combination of weight loss and sodium. And what we're looking at is the free of endpoint measure. And this simply means how many individuals do not have hypertension. How many individuals do not have hypertension? And over time, after you remove medication, this speaks to the power of some hypertensive medications. Everybody, or all groups, tend to develop hypertension. There is some increase in the prevalence of hypertension. That is to say, there's a decrease in the individuals that are free of hypertension. So it's a slightly backwards way to look at this data. The lower the number, the worse the scenario. The fewer the individuals that are free of hypertension. So you certainly want more. If we had 100% of individuals that were free of hypertension, fantastic. That's what we're aiming for, right? So in individuals that go off of their medication and are given usual care, so recommendations for diet and lifestyle but no monitoring, we see a rapid increase in the incidence of hypertension. And I said it specifically backwards because I think that wording makes more sense. We see a decrease in those that are free of hypertension. And it's lower at all time points over these 30 months of follow-up. Yeah, Keegan?
So that the fact that it's not at 100% at the beginning means that there's like a number of people who are taking these meds and still have hypertension, right?
Yeah, that's right. Yeah, so some people will be on hypertensive medication and still exhibit hypertension. It's controlled hypertension, but then many more will develop hypertension over these 30 months as they don't have the benefit of medication. Yeah, Peter?
Does it specify like how the weight was lost? Like whether it was exercise-based or dietary?
That is a great point, and I don't have that information. It probably does. The point that I want to get across here is the relative influence of sodium versus weight loss. I don't have that information, but I can find it for you. Yeah, I don't know how much of a difference there is in the impact on blood pressure of an equivalent change in exercise participation versus dietary lifestyle or dietary intervention. It's not so much like a change in obesity or insulin sensitivity where if you match the energy deficit, the result was the same. I'm not sure if you can do that same thing for hypertension or not. I don't know if that's ever been compared, to be honest, but it's a good point. So we know that it's not good to just get usual care. Anyone that either lost weight or reduced sodium saw a resistance to the development of hypertension, and the combined weight loss plus sodium reduction was the best case scenario. Notice those two aren't necessarily additive. There's a benefit to do both together, but you don't see a stepwise improvement that is additive for both weight loss and sodium reduction. Just that the combined therapy seems to mean there's less development of hypertension. A larger percentage of are free of hypertension at any given point in time. Man.
So here it's not additive, but before in exercise therapy you said that the effects are independent and additive?
Yes, so I wonder if this is a result of the residual effects of the medication, or if the point before is only for individuals that are pre-hypertensive. I'm not exactly sure. But they're additive in the sense that they both contribute to an improvement. They might not be mathematically additive, if that makes sense. Their effects add to both improve the outcome, but they're not an arithmetic addition, if that makes sense. Good catch. Yeah, not exactly additive, but they both contribute. So what would you call that then? It wouldn't be additive, wouldn't be synergistic. That's usually like an exponential or a greater increase than either on their own. Like a potentiation, maybe.
It's not kind of like adjunct therapy, like how you do, like for management of diabetes, you'd have
Adjunctive therapy? Yeah, could be.
diet and like metformin like a pill.
Yeah, yeah. Yeah, I'm not sure what you would call that. That's probably a good idea. Either way, better improvements, better outcomes with the combination of both, even though it's not linearly or mathematically additive. Now, you might have a slide on drug therapy with a table of drugs. I'm going to skip that because all of the thresholds are in relation to the old series of guidelines, but I do want to introduce some elements of drug therapy because it does have implications for exercise response and or testing. And so the most common types of medications, and there's many classes that you'll observe, are these listed here. And if an individual is pre-hypertensive or only in stage 1 hypertension, usually a less severe diuretic is administered. And so there are not large changes in ion contents or fluid compartment volumes. It's a mild diuretic that simply helps to remove some of the pressure in the arteries. Essentially drain some of the blood reservoir somewhat. And importantly, there's little electrolyte imbalance and it's used mostly for managing hypertension. It could be that that's the reason there are some individuals with hypertension at baseline in the last study. There's no differentiation based on what kind of medication they had, or at least to my knowledge. As hypertension progresses, though, individuals will often add to their thiazide diuretics a more potent medication. These are 3 different classes, even though it looks like they are subpoints. Beta blockers, diuretics, vasodilators are all different types of more severe medication. This is simply moved over to accommodate this picture, which is for better or for worse, but they're all different types. Diuretics are not an example of a beta blocker, I'll put it that way. Beta blockers are medications that block the beta adrenergic receptors. So essentially block the sympathetic nervous system. They blunt the exercise response. They blunt contractility. They blunt heart rate. They relax the arteries. Right? The sympathetic nervous system is responsible for constricting the arteries when you start exercising. And so beta blockers help to block that constriction. And that's good at rest for manipulating blood pressure. Less constriction means there's more room for the blood to flow, less pressure. Less activation of the heart means there's less blood being forced through. So if you think back to blood pressure equals cardiac output times total peripheral resistance, beta blockers will reduce blood pressure. It's good at rest, not necessarily good at exercise, right? When you move to exercise, you want activation of the sympathetic nervous system. You want heart rate to go up, contractility to go up. You want arterial constriction to go up so you can perfuse the muscles with blood. This is where you might exhibit or observe an abnormal heart rate response. So to Sadie's point, heart rate would go up with exercise, but for an individual with beta blockers as one of their medications, it might be blunted and not go up as much. It might be inadequate. And whether that results in exercise intolerance or premature fatigue or dizziness or fainting is a possibility, but that differs on a case-by-case basis. So beta blockers, one to poll individuals for and monitor heart rate for if they are taking that kind of medication to treat hypertension. There are also diuretics and vasodilators. There are various types of each. Importantly, diuretics try to focus on manipulation of ions within the vasculature or ions within the fluid, and they try to either excrete sodium or spare potassium, and by manipulating ion concentrations, they can have a secondary effect on fluid within the vasculature. So if you excrete more sodium at the kidneys, then more fluid will follow and also be excreted. Downside with diuretics and the resulting electrolyte imbalances are big time cardiac arrhythmia concerns. We talked about how potassium imbalance does affect cardiac rhythm. We didn't talk exactly about how it affects rhythm, just that it does, because it's pretty complicated and I didn't have the answer for you at that point. But certainly an imbalance in potassium will affect the cardiac cycle, and any extra depletion of sodium has pretty large thermoregulatory implications. Sensing the saltiness of the blood is one of the ways that we divert blood to the skin or to the muscle and decide when to sweat. So if you're exercising on diuretics, there's an increased risk of dehydration, confusion, inability to thermoregulate, and you get too hot, and so you might not tolerate exercise for those reasons. So concerns with diuretics. And vasodilators are very similar. ACE inhibitors and ARBs, angiotensin converting enzyme inhibitors. Remember the angiotensin-aldosterone-renin system to help regulate fluid within the body. If we disrupt the conversion of angiotensin to angiotensin II, we don't get that retention of fluid at the kidneys and resulting dehydration afterwards. And it's not necessarily the point to go through the stepwise conversion of angiotensin to angiotensin II, but just understand that it affects the fluid retention within the kidneys. ARBs are angiotensin receptor blockers, so even after conversion, we can block the receptor, we can block the signal that angiotensin would relay to the kidneys. So no specifics, just general overview of the types of medication and the main complications associated with each. Make sense so far? Yeah? Okay. Let's summarize. Hypertension. What do we learn in this section? Surprisingly, a large complement of Americans are diagnosed or have hypertension, especially now after the reclassification last year. And the best data that I can find, according to our previous classification, 1 in 5 Canadians had hypertension, and now it seems like we might be pushing 1 in 3. Not as bad as 1 out of 2 Americans, but certainly worse than previously. Large complement of the population has some degree of hypertension, and it's a leading risk factor for premature death and cardiovascular disease. And we don't really know what causes most of the cases. At least we don't know what one single factor causes most of the cases. We're pretty sure that the usual suspects are at play: sedentary lifestyle, poor diet, high sodium intake, but there's also some genetic predisposition to hypertension as well. But in 90% of cases, we can't pinpoint one thing that causes hypertension. The good news is we can modify it acutely. Even if you have hypertension, we can reverse or reduce high blood pressure after one exercise bout in free-living individuals. And that exercise bout can be aerobic, it can be resistance, at least circuit-like resistance, it can be vigorous, it can be moderate intensity. It seems to have an effect no matter if you're prehypertensive or hypertensive, and stringing together those individual bouts will help gradually return pressure to normal over time. Yeah, I don't know if I pointed this out, but in the first study that we talked about, the prehypertensive individuals, they were taking those mild TZDs, and so I thought it was an important point to bring up that exercise can improve hypertension even with medication. So the effects are in addition to those of medication. So there is some benefit to exercising even if you have controlled hypertension and are taking medications to address that. And what exercise? The exercise is fairly simple. 20 to 40 minutes a day, 40 to 60%, 3 days per week. If you were to boil down all the directives that we talked about and the classic prescription seen in all hypertension studies, this is what's been reported that works consistently in the literature. And now we're pushing the upper bounds of 60% VO2 max, and we're pushing the bounds of the type of exercise towards interval training and resistance. But we know this is fairly conclusive and does work. So if you knew anyone with hypertension, this is what you would tell them. We are confident in that statement. And that's all we got. That's hypertension. When do we end today? We got 15 minutes. I'm going to leave it there, only because I feel like it would be a disservice to try to start the next series of slides right now.